Good afternoon, colleagues, at the TBAC meeting. I'm sorry I could not be there in person owing to other commitments. I'm Barry Kistnasamy. I'm the Compensation Commissioner in the National Department of Health dealing with occupational lung diseases in mine workers. The presentation outline is as follows. Just to give the context of TB in mining, but TB in South Africa, and then the services that we provide as the Department of Health for current and ex-mine workers, and then some historical processes, lest we forget, where we come from in terms of the mining sector. So firstly, in terms of the context, there are multiple frameworks covering health, compensation, and other social protection benefits, and these are split between the Department of Health, the Department of Employment and Labor, and the Department of Mineral and Petroleum Resources. Secondly, the contextual framework is that the mining industry was historically built on migrant labor, not that other sectors of the economy are not. So migrant contract labor, and this covers both within and cross-border, the formal and informal economy, and large and small sectors. There are fragmented services for workers and ex-workers. And finally, we work with, in terms of governance, a diverse stakeholder and role player grouping that's government, employers, trade unions, ex-miners associations, and neighboring countries. So it's a very complex situation in terms of what we are working in. This is the history of migrant labor in South Africa. And you can see in 1920, 1 in 2 workers essentially were non-South African in terms of the mining sector. And the bulk of them came from Mozambique. And then as we went on, currently it's about 1 in 3 are non-South African in terms of the mining sector. This is what's called the TBVC, migrant mine workers, Transkei, Bophuthatswana, Venda, and Ciskei. And you can see that the bulk of the mine workers historically came from the Eastern Cape and what was called the former Transkei, euphemistically. This slide is important because of the 1973 modernization of the Act, the Occupational Disease and Mines and Works Act, which succeeded the 1912 Miners Thesis Act, which I'll talk about later on. This actually excluded the Transkei, Bophuthatswana, Venda, and Ciskei. And it's very sad in a sense of the workers who contributed to the mining economy were actually excluded from the compensation and assessment benefits. So trends in TB incidents, it's a busy slide, but just to say that South Africa has made substantial gains since 2009. If you look at the 2009 peak, we've been on a downward curve thereafter in terms of incidents being reduced by 57%, mortality in persons with TB reduced by 72%. And then the major issue was the provision of antiretrovirals in terms of the HIV positive grouping, which is quite linked to TB. This is the distribution of TB across South Africa. And what's noted is that the bulk of the metropolitan areas, you can see city of Cape Town, the Eastern Cape, in terms of Nelson Mandela Bay, eThekwini, and a bit of Gauteng, and the former, sort of the mining areas and what are called euphemistically labor-sending areas, actually have the high burden of TB. So we are saying that TB in mining should cover TB in mining sector, TB in peri-mining communities, and TB in labor-sending areas. And the bulk of the big metropolitan areas covers in the region of 60% of the TB incidents in the country. So we can make some interventions if we cover these major areas. This is TB in the mining sector where we were tracking, and historically, particularly in gold mining, the rates were 2 to 3 times the rates of the community in terms of the community-based rates. But it's glad to note that there's been a downward trend to date. There's still problems in terms of gold mining, but generally TB in mining has halved. And that's come through because of wider issues on overcrowding, provision of antiretrovirals, provision of dust control. So the social determinants of TB in mining were tackled with gusto through the Masoisa program, and hence we've had this downward trend. However, this is the disease burden that we face historically. If you look at the historical figures in terms of, and we pay compensation for this, look at TB, 77,000. If you then add another 13,000, you're looking close to 90,000, 100,000 ex-mine workers or mine workers with TB. Silicosis, 40,000. And these were the figures paid out. Now, many of these diseases other than TB are non-curable, and the social redistribution was through the compensation payments. I'll talk later on about the unpaid claims of amounting to 1.3 billion for 73,000 claims. So what we do at the Medical Bureau for Occupational Diseases and the Compensation Commissioner for Occupational Diseases, we provide medical assessments, including post exiting the the mining industry. We undertake claims adjudication to see that the mine worker, current or ex-mine worker, has got a medical assessment done and then is certified with a compensable disease. We then make payments if it's a compensable disease, and we collect revenue for the compensation fund, which is currently running at 5.8 billion rand. So what we consider in terms of the certification committee is the exposure history. What did the mine worker be exposed to? Silica dust, asbestosis, asbestos dust, etc. All those mines have closed. Coal workers, pneumoconiosis, coal mining, etc. There's a clinical assessment that's done made up of a chest X-ray and a lung function test. The chest X-ray tells us the extent of the problem in terms of the damage, and the impairment tells us how bad the damage is in terms of the process. This is a post-mortem specimen, healthy tissue in a 90-year-old school teacher. There's some specks. And this is the fibrotic lung diseases in a 40-year-old mine worker. And this is showing you a normal X-ray, chest X-ray, and a silicotic chest X-ray. Now, we had a legacy of neglect and system collapse in the Department of Health, and essentially this was one room of files. The telephone lines didn't work. We had to reorganize the entire system in terms of the administration based in Johannesburg. We developed an electronic claims management system. This is a busy slide, which the first part talks to lodgement of the claim electronically, the medical assessment process in terms of the provision of benefit medical examinations, the claims certifications process, and ultimately the payment process in terms of this. There's some other issues that we're working on: artificial intelligence, links to home affairs, SADC verification, bank account verification, etc., which is on the top part of the screen. So this is what we did to rescue the situation since new management came in 2012, brought in by Minister Motsoaledi. We've got a massive database, electronic, with digitization of files, currently having about 600,000 records and 200,000 digitized files. There's online access, which you can access anywhere if you have a web link. We undertake tracking and tracing of mine workers and ex-mine workers. Outreach activities. Currently, this week, there's an outreach in the Free State province with a benefit medical examination process with outreach activities, which I'll demonstrate in a minute. And Mpumalanga is coming up closely. We've increased the benefits in terms of the payouts. We're working closely with the class action settlement trust called the Siamiso Trust, which was a 5 billion rand settlement in the gold mining sector. And currently, they've paid out 1.5 billion. We're working quite closely with the Ex-Mine Workers Association. I'm sure Jabu Tsaba will comment a bit about the presentations. And then we undertake risk determination of new mines to control them. We're currently developing a database of current miners and health records that will come in, and then work on a new legal framework. So this is the update of CCOD claims over the last 25 years. In terms of, you can see that Lesotho, 20,000 claims were paid out in Lesotho, amounting to 643 million. There's still 5,000 claims unpaid, amounting to 124 million. Eastern Cape, 74,000 claims, benefit medical examinations done, 18,500 claims paid, amounting to 500 million. And then the list goes on in terms of the Free State, Northwest, etc. This is unpaid claims amounting to 1.3 billion. But bulk of the claims are before 2005. You can see we reduced the backlog for unpaid claims in the recent years. But unfortunately, this is a critical, vexing issue. We think that many of these ex-mine workers have died. And the different bars and the colors refer to the impairment rating of first degree, second degree, and TB claims, etc. So this is a concerted effort we are doing in terms of unpaid claims. We're doing data mining across multiple databases, TB registers, etc. And working with your organization, it is how do we actually pull together these records? We have to go back in Transkei records, Ciskei records. I talked about the TBVC countries. And there were problems in terms of information regulator approval. And we now have, from last year, the information regulator gave us permission to actually go and link with the different databases so that we can actually get a benefit to the current and ex-mine workers. These are one-stop service centers. Historically, mine workers would have to come to Johannesburg for the medical assessment. And these are one-stop service delivery units, decentralized, Mafeteng in Lesotho, Amtata in the Eastern Cape, Burgersfort in Limpopo Province, etc., in terms of opening up one-stop service centers. These are outreach activities, and I talked about our IT system. This is Matatil in the Eastern Cape, where mine workers came. This is the Deputy Commissioner under the tree looking up the claims record in terms of this. And we can't, unlike SASSA, we don't pay cash. So we take the bank with us in terms of opening up bank accounts. This was outreach activities that we undertook last year in terms of 5 districts in northern KwaZulu-Natal. And because we work with IT system, this is the road in Pongola going to Eswatini. We even launched a satellite dish in terms of not being dependent on information management systems from the mobile telephony companies. This is the former Deputy Minister visiting the reception center at Pongola, and together with the Minerals Council and the Director of District Health Services addressing the mine workers who are waiting in terms of the outreach activities. This is the Eastern Cape, also in April, undertaking some outreach activities, working with local communities. Yes, the Premier of the Eastern Cape accessing the mobile X-ray unit and speaking to the mine workers. So we work very closely with the Office of the Premier and the MECs for health in the different provinces and neighboring countries. We've moved quite far in terms of working with artificial intelligence and computer-aided diagnostics. This is the mobile X-ray unit, which does not rely, it relies on solar panels. We can now determine through computer-aided detection tools, whether it's TB or otherwise. We're working on a program now on silicosis and computer-aided detection. Reform, our act goes back to 1912. And, in terms of the Modernized Act 78 of 73, I told you that it brought in black mine workers because after the Durban strikes, unfortunately, between 1912 and 1973, black workers were excluded in general. Some of them did manage to make it into the system, but generally excluded. This act covered mainly white workers. After the Durban strikes, black workers got access to trade union organizing and trade union rights, and with that came access to social protection rights. The only difficulty was that if we paid for the same disease, silicosis, same impairment, for a white mine worker, we paid 10,000. For a black mine worker, we paid 1,000 rand. On the eve of democracy, the racial connotation was taken away in terms of the 1993 amendments, but overall, in 1973, it excluded between 1973 and 1993, Transkei, Bophuthatswana, Venda, and Ciskei, and definitely excluded Mozambique, Lesotho, etc., in terms of its access to compensation and medical assessments. Let's go to the history. These are the authentic works which talks about tuberculosis and the political economy of health and disease in South Africa. Randall Packard, who gave a major input, and many of the people in your organization should read this. Jock McCulloch has done some major work on mining gold and manufacturing ignorance, occupational lung disease, and the buying and selling of labor in South Africa, and how it devastated black workers in particular since the 1900s. But essentially, I told you it mainly was protective of white workers in terms of compensation payments and not black workers. 100 years ago, about 100 years ago, Saul Plaatje writes about the lives and livelihoods of mine workers in Kimberley in 1914. And he says 200,000. Remember, the mining industry today in formal employment is 500,000. He talks about 200,000 subterranean heroes who sacrificed their lungs to the rock dust, meniscitis and pneumonia. Remember, we didn't know. We knew it was dust-related, but it was a combination of TB and silicosis, which they called meniscitis. and many, many workers died. We had 2 international conferences. The first international conference hosted by the International Labour Organization in Johannesburg. So we knew there was a problem, male and pale. And this was the cream of the white medical doctors around the world who came to this conference in Johannesburg. In 1959, we had the second ILO conference. 1 woman made it through the ranks in terms of the process. So we're hoping that in terms of the next century, that we've made the interventions in terms of the social determinants of TB and occupational lung diseases, as well as redress, as well as interventions in terms of declining TB rates, dust control, and other inputs that can make workers go to work not to get injured, maimed, or diseased. Thank you.